We'll go ahead and get started. Welcome everyone. Very excited to have Dr. Gary Bennett from Duke University as our featured speaker today. Just saying a little bit about the i-BSHS seminar series, which is supported by the CV Star lectureship. And the goal is to promote collaboration, showcase innovation, and around health disparities. The major areas are around health disparities, community engagement technology that Dr. Bennett would talk about today, and intervention development. This is our seminar committee. I serve as a co-chair with Chris Kaler, and we're well supported by Kristen Ayala. The other faculty here are Katie Biello, Suzanne Colby, Made McGee, Jennifer Nazarino, and Tyler Ray, and our graduate students are Kira De Clemente and Rachel Neely. So I wanted to introduce Dr. Bennett, who we're very fortunate to have. He is currently at Duke University as the Bishop-MacDermott Family Professor of Psychology and Neuroscience, Global Health and Medicine, and he directs the Duke Global Digital Health Science Center. Dr. Bennett might be familiar to some of you as the past president of the Society of Behavioral Medicine. His research program designs, tests, and disseminates digital obesity treatments, and he is especially interested in integrating digital health treatments into the primary care setting. He's well-renowned for having developed the interactive obesity treatment approach, and his recent work demonstrates the effectiveness of coach-led digital obesity treatments. Dr. Bennett has authored more than 125 scientific papers, and his research program has been continuously supported by the National Institutes of Health. His research has also been featured in the New York Times, NPR, Time, CBS, ABC, NBC, Fox News, and we'll stop there, as well as many other media outlets. He's also served on numerous NIH committees, grant review panels, editorial boards, and guideline councils. He's also founded two digital startups, Crimson Health Solutions, which was acquired by Health Dialogue in 2007, and Scale Down, acquired by Anthem in 2017. So we're very excited to have Dr. Bennett, and Dr. Bennett, I'm turning it over to you.
Wonderful. Well, thank you so much, Anya, for that kind of introduction. I am, if you give me 1 second, hopefully my slides will magically appear. It's great to join you. I wish I could be there in person. I was just telling Chris that I desperately miss real snow. I'm sure none of you really want to hear that, but it snowed about what down here we call a quarter of a dusting about a week ago. And my little girls went outside at 5 a.m. and woke up the entire neighborhood throwing snowballs. I didn't have the heart to tell them it was like little mud balls. And so I desperately miss for a few hours what you all are experiencing right now. But my best to all of you and to your families through this pandemic situation. I thought we would try to cover a lot of ground today. So I'm going to see how far we get at some risk. I hope I'm going to try to tell you a little bit about our research program, which is in the nearing its second decade. And I want to show you a little bit about kind of how we are thinking about this issue of digital therapeutics for obesity in medically vulnerable groups. So hopefully this will resonate with some of you, and I look forward to the Q&A. All my fun disclosures to start with, but really let me start here, which is to say I'd be remiss right now to talk about anything without centering it in the current pandemic challenges that we're all experiencing. But I'll start by telling you about a woman named Miss Bannister, who was a school teacher down in Charleston, South Carolina, who was still early in her career, loved by her students. She was a great teacher and a great singer. There's some great YouTube videos of her. And she unfortunately lost her life to COVID back in September. And the challenge of this experience for so many families is that This is a condition that affects so many of us, and indeed, just a few weeks later, she lost her mother as well. This is a condition that has profoundly affected our entire country and has had particular and disproportionate impacts by race, ethnicity. Some of those data you see here, I think these are well known for all of us. Higher hospitalization rates in underrepresented minority groups. But I'm particularly interested in the connection between COVID and obesity. And I think many of us know that we see exceedingly higher rates of COVID severity with obesity. These are data from Barry Popkin earlier last year, a meta-analysis. Imagine doing a meta-analysis within a few months of the start of this thing. But we see greater severity with in the context of obesity. We see higher levels of hospitalization, and it's really quite linear. That is to say that as we reach into the higher stages of obesity, more likelihood to be hospitalized with COVID, and obviously an increased mortality risk associated with obesity as well. But the thing I want to note here is that this will continue to be an issue, even in the context of adequate vaccine distribution. Some studies, really, I think seminal studies at this point by my colleagues over at Carolina, show that with the previous influenza vaccines, that effectively it works less well among patients with obesity. We don't know this yet to be the case for the COVID vaccine, but it's certainly something that is being examined in some of these trials. This is a concern for all of us, and I think it illustrates, the ways in which we've really been contending, I think, with a dual pandemic in many respects. The pandemic before the pandemic was obesity, and it continues to be. Almost 140 million Americans right now are affected by the condition. And I think the challenge is that we've habituated to the magnitude of the obesity epidemic, such that we miss the fact that even over the last 20-year span, we've seen a pretty sizable increase in the prevalence of obesity. I think many of us imagine this thing is slowing down. It does not seem to be the case. I am particularly interested in populations that I'll call medically vulnerable. For me, that means that these are underrepresented minority groups, those who are socioeconomically disadvantaged, or those in rural areas. And in the work that I do here in North Carolina, we're really talking about all three of those groups. As many as 7 in 10 of those groups right now have obesity. And these disparities, particularly the racial ethnic disparities in obesity, are something that I think are worth continual mention. We have had disparities in obesity by race and gender as long as we've had good data. You can look at this tracking through the NHANES and its various predecessors all the way back to the middle of the 1950s. We've seen data that look like these, that Black women have higher rates of obesity that have been persistent for that period of time, and that gap has never closed. Data look a little bit different for men. And I think, as many of you know, obesity and gender don't follow the usual socioeconomic variability. That is to say, we have a generalized epidemic in obesity, one that affects particularly women, particularly underrepresented women, at a wide range of socioeconomic levels. And the challenge, of course, is how we're going to contend with this. I thought we would start by just kind of level setting a bit. I know we have many obesity researchers in the room, but I thought we would do some level setting here. If I look at guidelines, our evidence-based guidelines for the treatment of obesity, they look something like this. These are data from NHLBI from a couple of years ago now. But in general, to the dismay of just about everyone in my family who wants to ask me about how to lose weight, the answer is eat less, move more. And indeed, if you have the best outcomes are for populations that have a structured program that includes self-monitoring of your diet, physical activity, and weight, along with feedback from qualified interventionists. So this is sort of our guidelines panel, our guidelines for the treatment of obesity. And our guidelines have been informed and have informed trials like the diabetes prevention program. I put this here, there was obviously some significant Brown involvement in this work as well. The DPP, again, I know many of us know it, but just to level set, trial to try to prevent the transition from prediabetes to diabetes using testing lifestyle intervention against metformin against a control arm. And this is the lifestyle modification arm. It looks pretty similar in some respects to what I just showed you. Interactions with a qualified interventionist, changes in diet, physical activity, and a weight loss goal, and that clinically meaningful area. And in fact, this is the one of the more exciting things that's ever happened in behavioral medicine. But indeed, we see reductions in weight that are consistent with the goal that was attempted and was recommended, I should say, increases in physical activity. And then over the period of the immediate follow-up of the DPP, we see that the lifestyle intervention was superior to metformin and placebo in preventing that transition from prediabetes to diabetes. And that was maintained for some extended period of time. So this really, this is the intervention that I think for many of us, both in the obesity research community, but in the behavioral medicine community, this is the thing that gives us proves our worth in some respects. But the point I want to make is that, the weight loss treatment world, particularly that that's been delivered in an in-person delivery modality, has been largely sort of iterative. In the interventions that we've used have been both derived from trials like the DPP and LOOKHEAD, and they've also influenced the conduct of those interventions. That is to say, we haven't necessarily moved that far away from that kind of core intervention in most of the hundreds of intervention trials that have looked at obesity in the last 25 years. And so much so that we kind of call these kinds of treatments standard behavioral weight loss interventions or standard lifestyle modification interventions. The problem with this approach and this notion is that we've seen persistent racial ethnic disparities in clinical treatment outcomes using this kind of standard package. These are data, again, from DPP showing that over the 36-month initial follow-up period, we see less weight loss among Black women. Those are folks in the red group. Overall, we saw less weight loss among Blacks, but that's really driven by what happened for women. And the truth is, I could show you data from just about any trial that has ever enrolled sufficient numbers of diverse groups, sufficient enough to be able to look at group-based differences. That is to say that across the obesity treatment literature, we see smaller weight losses for those in medically vulnerable groups, and those losses are less likely to be clinically meaningful. It's a very robust finding, almost a law of obesity treatment. And of course, the problem is that if we look at our gold standard treatments, they frequently are in what we think of as that sort of 8 to 10% at 6 months to 1 year kind of range of weight loss treatment. Whereas we rarely, and I can't think of any time when we've seen that much weight loss in a medically vulnerable population, we generally see much smaller weight losses in the group. And the problem is that we tend to think of weight losses north of that 5% or 5 kilograms of weight loss as being in the healthful range, meaning that's the range that's really associated with clinically meaningful changes in cardiometabolic outcomes. There's some evidence that can start for some cardiometabolic outcomes at that 3% range, but in general, the problem here from a treatment perspective is that it's not just that we see a gap in clinical outcomes, it's that the gap is one that actually has clinical meaning. That extends to our trials that have been conducted in real world populations that in really the most recent trials. This is a trial from the group down in Louisiana at Pennington a couple of years, or just was published this year, but a trial that was aimed to produce weight loss in a cluster randomized fashion among patients in clinics down there. And you see really, I think there's a Herculean effort of a trial, but over a 2-year period of time, good weight losses, very strong weight losses in all groups, but significantly smaller weight losses in the group that was comprised of Black population, using a fairly intensive intervention design, I should say. And so the problem for us in many respects is that, I'll say, I hope reasonably provocatively, ask your doctor is a pretty good recommendation for just about every clinical treatment option except for obesity. And we would expect to be able to find evidence-based clinical treatments in the primary care setting. But in fact, we know that only about 20% of patients who have obesity actually receive counseling in the primary care setting. And challenges that the patients that are least likely to get the counseling are those that tend to have the highest prevalence of the condition. And I'm not trying to beat up on my physician colleagues here. I do need to occasionally walk through the hospital from time to time. But there are really good well-known kind of reasons for this, and you see some of them here. These have been robust and seem to be persistent across a wide range of different kind of clinical settings. I will point to the last one though, and this is a bit tangential, but reimbursement has long been identified as a major barrier to obesity, to the uptake of obesity treatments, particularly evidence-based obesity treatments. And some of you might know that within the last couple of years, CMS has allowed for reimbursement to physicians and qualified providers who work with them in the primary care setting. It's not a ton of money for physicians to do this work, but there is a reimbursement prospects. And even then, we still see very little uptake among eligible patients for using this kind of obesity reimbursement scheme. In short, we just have few options for patients, particularly those who have the highest prevalence of the condition in the modern primary care setting. So, to summarize, we have medically vulnerable populations have higher obesity, higher rates of chronic disease that travel along with that obesity. They drive higher healthcare costs across our health system. They're less likely to be treated. And when they are treated, they're less likely to be successful. This is the public health challenge that we've been facing for some period of time. But if I go back and I look at this constellation of treatment options that we described earlier, again, what we think of as the gold standard treatment approach, I'd ask you, what are we really thinking of? Like, what would really be required to take this package and to employ it in a durable, kind of scalable way in the modern health system? That is to say, like, what are we really asking patients for when we use this kind of treatment package? And the answer is, what really leads to success in that gold standard kind of treatment package is that we have highly trained providers. You have to have a patient population that has pretty significant discretionary time. Many of the folks I work with in our trials, would either have their pay docked, receive a demerit, or could be fired for taking time off in the middle of the day to go spend an hour with a highly trained interventionist. You have to have high weight loss motivation. In fact, many of our trials have run-in periods that ensure that is the case. And what we know about obesity treatment is that a good number of our patients have no expressed motivation to lose weight at any time. A lot of what we ask people to do requires high literacy and numeracy skills. Keep track of everything that you're eating and drinking, create a budget of your calories. That's challenging. It's a challenging cognitive task. Many of our trials enroll participants that have limited comorbidities. And we know that out in the wild, that's not something we encounter very often. And these treatment cost a lot of money. I challenge you to think of anything that we encounter in the modern health system that requires 16 weekly visits of an hour with a clinical provider. There's almost nothing like that. This drives a lot of cost. And as a consequence of that, we've seen relatively limited uptake in the health system. So these are things that in my research program we've been thinking about, and all of these challenges are the reasons that we have moved into digital as a treatment option. I thought I might just spend a few minutes orienting us to kind of what we know works in the digital treatment for obesity, just as a kind of for a little bit of time, because I think it will help to tell the story a bit of why we do what we do the way we do it. And so if you kind of look at the literature in this space for digital treatment of obesity, what really works, I'll start by saying I want to make a distinction here. And that is that if you go out on the street today and you ask 10 Americans what they should do to manage if they want to lose weight, I think probably 8 to 9 out of 10 will tell you they're going to go download an app. These apps have completely changed the way that most Americans think about managing their weight. I can't describe to you how large these numbers are. These numbers are dated, but if you just look at the sort of active users, these vastly exceed what you see for apps of a wide variety of other categories. The problem is that we know that most of the apps that most Americans use to manage their weight don't work very well. We see suboptimal outcomes, particularly suboptimal short-term outcomes, very little evidence of long-term outcomes from some of these apps. They don't necessarily include, and in fact, we know in most cases they don't include the kinds of evidence-based components that we know to work in the evidence around in-person obesity treatments. So this is a major challenge. So I want to hold that aside for a second. If you're interested in the dissemination prospects or dissemination challenges in this space, I'm happy to talk about that. But I'm really going to focus on research grade digital treatments, and it's important for me to disentangle the two. If we're thinking about treatments that have been created in the academic setting, then in general we see that these treatments can produce up to about a 5 kilo or 5% weight loss at one year. And I'm going to ask anybody who is quantitatively inclined in the audience to kind of avert your eyes for the next slide. This is what I call a gist slide. This is designed to convey the gist of a whole series of studies. So there's nothing sort of meta-analytic about this. But what you see here are studies of one-year outcomes from trials comparing digital treatments to non-digital control arms. So an active treatment arm that's non-digital in nature. And this represents the delta between those two. And so in general, you see that most of our treatments fall within that kind of 1 to 2 to really that ceiling of about 5. But really most of the trials produce somewhere between 2 and 4 kilos of weight loss at follow-up at 1 year. So we're not hitting huge weight losses from digital treatments, but they are treatments that perhaps have a better chance of ultimately being disseminated in the modern health system. In general, you see that represented in a different way. Here, again, are in-person kind of gold standard treatments. We tend to get between 8 and 10% at 6 months or 1 year. And we see something less than that from most of the trials that are conducted. So right at the bottom of that health sort of range of clinical meaning. And so we still have some work to do here, but nevertheless, these have great potential. So if I'm thinking about how to optimize the outcomes from these trials, we're really focusing on what works. I'd say the first thing is, we have to engage our users. That's an obvious point for many respects. But indeed, we know that when patients use more, they will lose more. I just point to a systematic review that's on its way out from one of my students, Shelley Lanfer, who's now at Stanford. And what she basically shows is that across the digital landscape, self-monitoring is one of the is the most consistent predictor of weight loss outcomes. We know that to be true in person as well. So we want to try to get people engaged. You can look at this in a variety of ways. These are dated data now from one of our trials. Would be Fit Be Well. This is a 2-year trial of a web-based weight loss intervention in primary care settings in Boston. And what you see very simply is on the back end of the trial, if you go back in and you see how many logins we had, logins are positively associated with weight losses at 2 years. These are data from Bonnie Spring out at Northwestern. She was using kind of an app-based approach that was compared to a standard treatment. And what you see in general is that when you are more adherent, you lose more weight. And when folks are using a mobile treatment and they're more adherent to that, then they lose significant amounts of weight. So engaging our users is absolutely critical. The key challenge in digital treatment is that disengagement is absolutely normative. It's normative in all types, all modes of intervention delivery. But this is something we have to really pay an eye on in digital treatment because we don't have human accountability to help us. So in general, what you see is disengagement. These are data from Laura Burke from a couple of years back, and she looks at essentially engagement with self-monitoring. And over a 2-year period, you see significant a slope decline in the rates of engagement. And you see somewhat steeper slopes for papered versus mobile, and particularly mobile with feedback. So this is actually a really, it's a good thing for us. The challenge in obesity treatment is not trying to get somebody to use your device or your app or your treatment next week or next month. It's how you keep people engaged for 8, 9, 10 months. It's a completely different behavioral challenge and design challenge. And so we have a little bit of help here with data like Laura's. But I'll note that this challenge of engagement is a challenge everywhere in digital. This is not just unique to digital treatment of obesity or digital therapeutics as an area. These are data that are basically combine across all the apps in the App Store and look at the average churn rate. That is the likelihood that a participant is going to leave your app. And what you see, these data have been consistent for about a half decade now, is that by the time you get to the 3rd month after somebody's downloaded your app, about 70% of the folks have stopped using it. This is the key challenge. In fact, I sometimes say, like, when we tell people on the West Coast how good our engagement is in our trials, in our digital treatment trials, nobody believes it, because the norm is actually to see disengagement of this type. And so that's really the key thing, is engaging users. Number two is integrating coaching. And this may seem a little bit counterintuitive, but I have to tell you, one of the fundamental contradictions in the entire digital therapeutic space is that most of the time when academics are talking about digital treatments, particularly in the obesity space, we're talking about digital treatments that also include humans. We have very, very limited evidence of standalone treatments. One of my students, Christina Hopkins, did a systematic review in the obesity treatment space and looked for trials that were completely standalone, that is digital only, no humans involved. We actually have relatively limited evidence in this space, and just about 8 studies. And in those trials, only 3 of them showed clinically meaningful weight losses over at least six months. And those clinically meaningful weight losses tended to be on the smaller end of the range. And so that's a long way of saying that the kinds of treatments that we are often, when we're talking about digital therapeutics, I think most of the folks we're talking to imagine that we're talking about app-only approaches. We know very, very little about how to do that well. And so I want you to keep that in mind. It's a major challenge in our field. In fact, these are data from a trial I was involved with my colleague Lars Fecke here at Duke in the early trials consortium. And what you saw here is that we had an in-person treatment arm. We compared that to an app that we built, and in fact, the app underperformed control. App-only approach underperformed control. These were depressing, let's be clear, but not entirely surprising findings given the literature that we have in this space. And I have to point to design. Again, I know there's a lot of students in the audience, and I just want to point to one issue. We underplay the importance of design here, right? Like you hear a lot of academics say things like, "We'll make it pretty later," or "It's not that attractive, but." The problem is that the pretty makes it more functional. And we know, if you talk to our industry colleagues, they spend a lot of time on pretty, not because they care about making it pretty, but because they know that makes it work well and keeps people engaged. So, if you looked at our app, you might wonder how it compares against other types of industry grade apps. And the answer is that it doesn't have the kind of design components that we know really produce larger engagement and larger outcomes. I'm spending a lot of time right now doing work using the multi-phase optimization strategy, which is a way of disentangling the kind of black box of a lot of our behavioral interventions to examine kind of where our active ingredients really are. The hope here is that you can sort of optimize treatment packages where you have a very clear sense of what works to produce the outcomes that you're interested in. Happy to spend more time talking about it, but I just wanted to drop this here because we're spending time now thinking about how to create standalone treatment apps that can produce clinical meaningful outcomes. And we're starting with design manipulations. So this is a trial that we have that just came out of the field where we were doing essentially a factorial experiment. We picked 5 different design considerations, each with 2 levels on or off. Or you can think of in some cases it's sort of evidence-based versus something else we're trying to try. So you can see some of those here, and we have 32 different levels of this treatment to which patients are randomized. Important thing here, and again, I'm happy to talk about this, but I'm really putting this for our students and trainees in the room. What MOST does fundamentally is that, there's a lot of times when we're designing behavioral interventions, particularly in digital, where because we don't have a robust literature, we're kind of relying on best practice, what works in person, or we're just making it up. And in many respects, those decisions that we're making, we really could be driven by the data. What MOST does is it allows you to pick some design components in this case and determine kind of what works. So what I did at the beginning of this trial is I went around to all the investigators on it and I said, what do you think is going to comprise the optimized treatment package at the close of this? I.e., if you had to design this treatment yourself, what would you pick? And I can tell you that there was no investigator in the room got it right. The data told a completely different story about what worked. And I think approaches like this can help us to get a little bit better in optimizing some of these treatments. But for the meantime, humans aren't going anywhere. I started doing this to get humans out of the business, but I think humans are going to be around for a little while. And I really am excited in the primary care space about the ways in which digital actually amplifies what humans do. You can look at this from data from my colleague Deb Tate at Carolina, and she shows, basically an email intervention in this basic internet group. But when you add behavioral email e-counseling to this, you see larger outcomes. We see this in many different places. That is, you add some type of human counseling to a standalone treatment and you get better outcomes. And so there are particular areas we've been very interested in kind of how to manipulate the use of humans in an efficient way, a way that may have scale and may minimize costs and may deliver larger outcomes. And I'll talk more about that in a minute. We know that these kinds of different human counseling approaches seem to work more or less similarly. So these are data from Larry Appel's group at Hopkins from a couple of years ago. He randomized patients to one of three arms, either control or functionally a web-based intervention arm that had human support provided either remotely from a coach at a large disease management company or in-person support delivered by one of our usual interventionists. And what you see is that at the trial close after 2 years, there really wasn't a difference between the two different ways of providing human support. And this is, I think, probably the most seminal primary care-based weight loss trial. But this gives us a lot of liberty in thinking about how to employ human counseling in interesting ways. Telephone, chatbot, perhaps using in-person really, really selectively. We want to use effective devices. My apologies to anybody who's wearing a Fitbit right now, but we know that in general, adding a physical activity monitoring device to weight loss treatment doesn't work as well as we would like it to. We've seen a couple of trials that have tried to do this. Probably the best example is from John Jakisik from a couple of years ago, combining a wearable with a standard treatment arm. Doesn't really produce larger weight loss outcomes out to 24 months. But the reason for this is understandable, probably. We know physical activity itself doesn't lead to much larger weight losses for weight loss initiation. It's much more useful for weight loss maintenance. That's probably the driver. We've been doing a lot of work in daily self-weighing in the last half decade or so. And so we think about other devices that we might employ. And that's really based on data from my colleague, Dory Steinberg, who showed that, giving patients a network connected scale and giving them the recommendation to weigh themselves daily and follow feedback that she provided led to really considerable weight losses relative to our expectation. And when you think about this kind of a treatment approach, just providing this kind of digital scale, giving really sort of personalized feedback and asking patients to follow along, you can imagine ways of composing a digital therapeutic that leverages what's actually happening with the outcome that you're trying to produce and helps to sort of personalize the data therein. So I'll talk more about that in a second. We know tailored feedback really matters a lot. This is really clear in the daily self-weighing space. When you weigh yourself without feedback, we see much smaller weight losses than you do when you provide tailored feedback. I could show you 100 studies that say something very similar. So thinking about the utility of our data to provide actionable insights at the patient level just is absolutely critical. And then the last thing I'll note is that anything we can do to reduce the burden, the cognitive complexity of this task is to the good. And so we've been thinking about, you'll see this in just a moment, ways that we use digital treatments to digital modalities to make this an easier process for our patients. We're not where I want to be yet, but we're getting there. And so if you take all that in mind, you've got this public health challenge of obesity, the major clinical gap, the lack of treatment deployment in the primary care setting, and you combine that with, that's the sort of challenge that's facing us. And then you take the sort of digital therapeutic literature, with all of its various challenges, but in all the caveats noted, it sort of, for us, has sort of led to this, which is what we call the interactive obesity treatment approach. iOTA is a response to this public health challenge, and it tries to leverage what works best in digital, where fundamentally, we're disinterested in leveraging kind of doing what a colleague Vic Strecker called the digital pamphlet rack, the idea that you should take what works, take an in-person treatment and just deploy it digitally. We're really interested in trying to find ways of using what works best in digital and really trying to leverage those kinds of digital features to produce the kinds of outcomes that we hope to achieve. Just stick with me here. So I've asked earlier if you're quantitatively inclined to avert your eyes. Now, if you're an exercise physiologist or kinesiologist, just please avert your eyes and stick with me here. In general, if we're trying to produce 1 to 2 pounds of weight loss a week, we're shooting for something like a 500 calorie deficit each day. And you can get there in a variety of ways. I can ask you to track everything you're eating and drinking and kind of create a calorie budget, and I can give you very strict goals, and that works extremely well. The other way you can get there is that I can ask you to do a couple of really common sense things. And you see some of those examples here. Don't snack, get 10,000 steps, don't have any sugary drinks. Each one of these things has a kind of a calorie deficit attached to it. There's a lot of error in these estimates. There's no doubt about it. But you can imagine that you could create a scenario where you could have these behavioral goals, understand what the calorie deficit is, and you could pick them in such a way that they sum to this number, like this magic kind of 500 calories a day. The challenge would be figuring out who should get what goals. And so you can imagine a kind of a constellation of goals that you might have for a woman who is, say, premenopausal, and that may look something like this. But if you had sort of an older man, you would imagine there might be a slightly different set of goals that you'd want to pick. And so in iOTA, what we do is we've created a whole series of algorithms that at first thing they do is they select goals for patients based on that patient's need to change a goal, their psychological readiness, their self-efficacy, and the caloric deficit that we're trying to achieve. Early on in treatment, we're trying to dial up the calorie deficit. As we achieve weight loss goals, we might try to dial it down. If we're doing weight gain prevention, we might dial it down, those kinds of things. And so what you do is, you have a patient, she sits down, she fills out a survey. Their data go into the sky, they run up against our algorithms. We dig deep into a goal library that we've created that has several dozen of these goals. I should tell you, when you see them, they look simple. They are supposed to look simple. They're supposed to be face valid. My wife sometimes says, do they pay you to write these things? And the answer is yes, because as Steve Jobs said, simple is hard. It is very challenging. But again, we're trying to consider the literacy and numeracy challenges that are rampant in our patient population. So if they look easy to us, they should look easy to our patients. And we then assign folks those goals. And then we ask them to go off and self-monitor their goals, their adherence to those goals. We design self-monitoring interfaces that are simple to fill out, that often require dichotomous response options. Fundamental in our approach is the idea that real people don't like numbers, scientists do. And that one of the challenges that we have is that we are asking people often to monitor things in the easiest way. So instead of saying, how many steps did you get today, we might ask something like, we might ask about steps, but for example, for minutes, we may not ask sort of minutes of physical activity, but we would say, did you hit your goal of achieving this number of minutes each day this week? So those kinds of things, more dichotomous response options. To that self-monitoring, we provide personalized feedback. We use a 1-to-1 ratio. Everything that we get from a patient gets responded to with personalized feedback of some sort. We integrate devices and then flow those data in ways that can be useful in providing the feedback to patients and to their providers. And in many of our trials, we use human support, as I described earlier. We often work with registered dietitians who are employees in the health systems where we deliver these treatments. We think a lot about who wants to see what. That is to say, our registered dietitians want to see all the data that we have about a patient. So we create dashboards that allow them to dig deep. They have a curriculum, but they have the ability to kind of see everything that every piece of data that a patient tracks and everything we know about that patient over time. Our providers, our clinicians, physicians, they don't want to see that much data. They just want the facts. And so we design prompts that get dropped into the electronic health record that include summaries of what's been going on with the patients and include almost scripted language that a provider can use when she's working with one of our patients in clinic. I should mention that in our trials, we update these electronic health record notes every time we see a patient, so that every time a patient tends to see a physician, 3-4 times a year, every time she sees her patient, then those data will be updated. So I thought I'd tell you about how this all comes together and just present maybe just a couple trials very quickly. One of these is called TRACK trial we finished a couple years ago, 2-year treatment of a behavioral digital therapeutic for obesity in the primary care setting. And here, one of the joys of working in these settings is that the electronic health records in a lot of the community health centers where I work are relatively new, and they provide a lot of functionality that would be harder for me to actually achieve here at Duke. And so we have here a track was designed to really link patients with their providers, who are their clinicians, along with program coaches who are registered dietitians who usually provide WIC care in these health systems. They all have RDs and all trained to do weight loss treatment, but don't get a chance to do it that often. So they enjoy doing this kind of work. our health systems look a lot like the federally qualified community health centers all over the country. We have a high proportion of underrepresented minorities and the working poor. We are not like a lot of Northeastern states, and we don't have any insurance guarantees here. So we have a lot of folks who don't have insurance. Track enrolled patients, you see demographics here, mostly Black women who are, have some college education, and again, are really in that working poor space, and heavily uninsured. About a third almost are smokers. Many folks have chronic conditions. I should say the condition of eligibility for this trial was having obesity and a cardiometabolic condition, either hypertension, diabetes, hyperlipidemia, or all three, and about 20% had all three. Most in every trial we've done, and we see a floor of about 20% who are depressed. I'll note you see this level of depression in many obesity treatment trials. The difference in this population is that obesity and depression are not as connected. That is to say, that body image is not as strongly connected to weight in these populations. And the other challenge, of course, is that when you see 20% depressed in our trials, it means that none of these folks are the vast majority of these folks are not receiving treatment of any type. And I'm going to get back to that in just a second. In general, we see weight loss outcomes. This is the lead. I'm not burying it. Over a 12-month period of time, that in about that 4 kilo range, using this intervention package that I described earlier. That's pretty consistent with what we would expect to see in the primary care setting in more advantaged populations. So back to the trial I mentioned earlier from Larry Apple and colleagues at Hopkins a couple of years ago. They also had about 4 kilos of weight loss a year, much more advantaged group of patients, different type of treatment. But so in general, with this kind of highly digital treatment in populations where we don't get large weight loss outcomes in most cases, we get around where we'd expect to be or hope to be for in a primary care-based trial. If you ask yourself, who's likely to actually do this thing? Who's going to use these kinds of treatment approaches, using text messaging to track their goals or using interactive voice responses to track their goals over the period of a year? I can tell you that if we look at our sort of goal rate of engagement, which is using the app for weekly over the course of a year, more than 90% of our patients do just that. But what's the reason, and again, for the students in the room, focusing on engagement is just so important, is that when you use more, you lose more. So if we look at folks who kept more than 80% of their coaching calls, that's about a quarter of our sample, they lost much more weight. If we look at folks who did 80% of their tracking using our digital apps, they lost much more weight. If we looked at folks, that was about a quarter of the sample too. If we look at the third of the sample that actually gets more than 5 days a week of weighing, we ask them to weigh themselves daily. So this is a high level of daily weighing. We get considerably much more weight loss. So, really engagement is the name of the game here. And if we can, I'm pretty confident if we can dial up these engagement outcomes, we can get to better clinical outcomes. For the first probably 10 years of my career, we didn't do any work that actually engaged clinicians in the delivery of these treatments. I will not do that anymore. You can see this is another example of one of our electronic health record based notes for this trial, for the TRACK trial. And we went back and we did a study. My colleague Megan McVeigh, who's now at Florida, did this work. And we asked patients whether they received counseling from their provider. If they said yes, we said, okay, so what kind of treatment did you receive? And in general, what you find in this is that if the doctor said something generic about diet, eat a little bit better, patient, we saw no additional weight loss. Same thing for exercise. Go out and get more exercise. We saw no weight loss. If the physician did what we asked them to do, and actually mentioned the study and said, look, I think being in the study is a good thing for you. You seem to be doing well. Keep it up. This is great. If the patient actually reported that, and this is another example of one of our treatment notes. So we saw an extra 4.5 kilos of weight loss at follow-up. And so this kind of approach, again, this is not a surprise from the behavioral accountability literature. We see this kind of thing all the time in in-person treatment. But this for us has sort of validated the notion of providing these very short counseling notes to our physicians and asking them to engage their patients this way. We get bigger weight loss outcomes. I think, I'm going to go through each line here because I want to show you kind of how this, I'm kidding, we're not going to go through any of this. I just want to point here to the middle, which is to say that the other area that we work in is an area called weight gain prevention. This is not maintenance of weight loss. This is the prevention of weight gain among patients who already have overweight or low levels of obesity. That is to say that the primary challenge in comprehensive obesity care is the idea that that you're going to encounter patients who don't want to lose weight, and our clinical treatment guidelines say that you should tell them not to gain weight. I challenge you to go tell somebody not to do something. Generally, it doesn't work that well. So we haven't really had a lot of trials, a lot of interventions for how to achieve this. I want to just show that. So in general, about 60% of our patients who we see who have obesity in a primary care setting will have no interest in losing weight at that moment. And much of what we know in the obesity treatment literature is really founded on treating motivated patients. This is much more common among medically vulnerable patients. So I'll note that this is an easier treatment endeavor because you need about 500 calories to lose a pound a week. You only need about 200 calorie deficit to prevent weight gain. And so we did this kind of approach and shape. I'm going to breeze through this in the interest of time. But the idea here is that we enrolled women who were premenopausal and had overweight or stage 1 obesity, that is a BMI up to about 35. And we were trying to prevent the weight gain. The idea here being that what's really dangerous about obesity is that annual weight gain is very common among women, especially common among Black women. If we can prevent those weight gains, it would be a nice second line treatment offering. You see the kind of patients demographics we have here. Again, note the depression levels. And this group of women who are young and have low levels of obesity are already beginning to evidence some of the challenges that are to come. iOTA-based intervention, we did weekly self-monitoring using interactive voice response here. So kind of talking to an automated telephone call. We record thousands of hours of actors recording snippets, and then the software pieces together those snippets of audio recorded information on the phone call. So it sounds like you're talking something like to a real person, and they get personalized feedback. We used coaching support, 12 short calls. So we had about a monthly call for the registered dietitian. And again, if you ask who does this, the answer is more people than you might imagine. So if we just measure engagement as a function of who's tracking using interactive voice response, about 3/4 of them did. About 85% or so took their coaching calls as prescribed. And again, not bearing the lead, over an 18-month period, you see weight gain prevention. That is, in the control arm, we should expect to see that kind of 2 to 4 kilos per year increase in weight that's so common among women of this age. But that is sort of important, the sort of primary outcome of most of our patients being more likely to be at or below their starting weight at 18 months. That's great. Again, we see the same kind of findings with engagement, more engagement, deeper weight losses. I'll note that we enrolled people here who were not interested in weight loss. We didn't talk about weight loss. This is not a weight loss study. It was just about preventing weight gain. We talked about things like having more energy and having more time for yourself and minimizing stress, kind of more wellness-ended targets. But in fact, if you get engaged, people actually lost a little bit of weight. This worked across literacy levels. That is, measuring literacy. Again, Shelley Lanford did some really nice work showing this kind of approach works pretty well, irrespective of your literacy. But what's really important is we came back 4 years later, we did a chart review of folks who were randomized to this trial. And we found that over that 4-year period, 4 years post-randomization, we'd seen maintenance of that weight gain prevention. That is to say that we did not see the rates of weight gain that we would expect to see. And indeed, the rates of weight gain that we saw in the control group over that 4-year period of time. So very simple intervention, 12 months in duration, largely digital, not really focused on weight-related endpoints, produces pretty durable outcomes. And my colleague Dory Steinberg showed that this approach, which again didn't talk about mood, didn't talk about depression, didn't talk about any real emotional targets beyond having more time for yourself, taking care of yourself, kind of a self-care kind of perspective, reduced depressive symptoms in this population by about 70%. We think we know why that might be the case. These kinds of treatments for untreated populations look a lot like the kind of behavioral activation treatment of clinical depression. That might be what's going on, but we think this is a real good. And I have to tell you that from a dissemination perspective, the thing that excites most of our clinical partners are these data. This is really what gets them excited, the idea of being able to touch multiple endpoints, multiple outcomes. We are now testing this approach in a pragmatic trial across a large health system, and we're trying to minimize the cost associated with the human delivered portions of the intervention. So everybody in the current trial, which is called Balance, gets a scale. And when they stand on the scale, if they're not gaining any weight, they just continue to use our app. If they gain a little bit of weight, they get into the yellow zone and they start getting texted from one of our coaches. These are registered dietitians who work at the health system. And if they get into the red zone, that is, they gain more weight than they sort of exceed our weight gain threshold, they get a telephone call from one of our coaches. And so that trial will come out of the field in just a few weeks. So in summary, I know I covered a lot of ground. I hope I could keep your attention. The idea here is that we need to do comprehensive obesity care. It's not just about weight loss, particularly in medically vulnerable populations. We also have to think about weight gain prevention. But these technologies can be extremely useful for achieving both ends, for achieving scale, I think increasingly for minimizing costs even in these really challenging healthcare settings. We're focused, again, both on first-line treatment and second-line treatments, weight loss and prevention of weight gain. I think that's a really critical combination. And in both cases, we see changes in emotional outcomes that, again, are of great interest to potential adopters. My summary point, though, is, when I started doing this work, many years ago now, I used to get comments from reviewers that would say things like, don't you know folks in this population don't have computers, or haven't you heard of the digital divide? I mean, these are literal quotes from my pink sheets. Now, I'll tell you with some confidence that these kinds of approaches aren't just one way to reach into medically vulnerable populations. I think they're actually the best way for reasons that I'm happy to describe if you're interested. So I'm going to stop there and take any questions you might have.
Thank you, Gary, for that wonderful presentation. As I said earlier, if people had questions, they can put them in the chat. One quick question I did have was, I noticed that you have people tracking, their diet as well as their physical activity. I wondered whether you also include sleep as well.
Not yet. Not yet. It's the number one thing our patients and our clinicians ask about. We don't include it yet because I'm not convinced we know how to deploy the interventions in a way that are actually quite yet. So I think that's going to be the next step. But to your point, it is the thing that people ask the most about these days.
You also have some great questions here from Kim Gans. She first would like to know if you could talk a little bit more about the recruitment strategies that work for you.
Hey, Kim. So we do these days I'm mostly doing, so for the last couple of years, we only do trials really in health centers. And so in the early years, we used a combination of approaches. We used both physician referral, and we also use the kind of standard, we generate a list, send everybody a letter, and then contact them by phone and do that kind of thing. I'd say that kind of approach actually has worked the best for us. In more recent years, we're moving much more to pragmatic trials. So, in the balance trial that I just described to you earlier, we never see those patients. All the recruitment is done by folks in the health system. And so the positive thing here is that the physicians are so excited about these types of treatments. They're always looking for an additional tool in their clinical toolbox, that they've been really, really wonderful referral partners. It actually has been easier in more recent years as we've moved to pragmatic trials, because clinicians are used to thinking about referring patients to programs that the health centers are offering, and less comfortable referring people to trials. And I know that sounds a little bit confusing, but in fact, clinicians think about these treatments as things that are programs that are being offered, and we sort of manage the sort of research details on the back end once we hear from them. Those approaches, I think, have worked really well. The last thing I'll say is that in the CHARGE trial I was describing earlier, that factorial study, we've done a ton of work on social media. That was the fastest recruitment I've ever done in my career. We recruited 600 people in a month and a half. And we did that exclusively through Reddit, through Nextdoor, and through Facebook. It was astounding and concerning.
Kim, would you like to ask your other two questions?
Sure. So I was wondering about your control groups, what you do for your controls. Is it usual care, wait lists, some other intervention? So I'll ask that one, and then I'll wait and ask the one after that.
We do usual care. And the way we do usual care, in these settings is to come in and to do pretty significant kind of continuing education training for the clinicians in the health system. And we do provide them with materials, but they tend to be the kind of written materials that we all know about. But we do a lot of training. And then we, on the back end of our trials, we generally make the treatments available for patients who are interested.
Okay. And one more question. I don't want to monopolize your time, but one of my older studies now, Sister Talk, video, and I'm wondering if you've used any video or incorporated that into any of your interventions. I mean, the way that we did it, it was like a television show, and then we had actual like tapes, and now we've got streaming video, and you can do things in little chunks. And so I'm just wondering if you've used any of that, what your thoughts are about that. Any thoughts you might have.
Well, I know Sister Talk well, and it was awesome. So no, we don't do anything quite that good, but we do use a lot of video. And we've moved. I've been again. I'm a bit of a design nerd here, and I've been really interested in some of these questions. I think that are kind of understudied about the sociodemographics of the actors in our videos and how implicit biases may be working against or for us. And so we've sort of leaned in a little bit on the literature on what do you call them? Gosh, I'm totally blanking on it. On sort of the emotional
paraprofessionals,
community
health workers. Yeah.
Yeah. More on the sort of parasocial relations. So the emotional bonds that sort of can get formed with some non-human actors or kind of from the entertainment education literature. So we've been using a lot of these of avatars and kind of virtual kinds of products, which help us to create the videos more inexpensively and iterate on those videos a little bit over time and do a better job of kind of matching the videos to some of the patient characteristics than we would be able to do with actors. I have to tell you, we haven't studied that piece well enough for me to be very comfortable with it. But I have to tell you, the thing I'm most interested in this space is all of the work on the deep fakes. So the idea that we can basically use AI to create people who we would like to create. I think the next frontier for us in the video is using kind of deep fake technology to match people with images of clinicians that we think might be best suited for them. So if you could figure out kind of who is the optimal clinician, you could create that person in a virtual context. So we're just beginning to think about some of that stuff.
Great, thanks.
Well, Taylor Ash also had a really great question about your process for developing your technology, whether you work with a target population to inform the content and or design. So I think this will be great since you say you're a design nerd. So I think you'll like this question.
Yeah, no, I fear you won't like the answer. So I'll tell you, I'm also, I'm a design nerd, but I'm also a struggling and not particularly great software engineer. So, I spend a lot of time, attending to that literature. I have to tell you, the way this kind of early stage software development is approached in industry is often to not use focus groups, not to do deep qualitative inquiry. The idea, I think Steve Jobs said it best, which is people don't really know what they want. And that is to say that if you're asking a person what they want to see and they've never seen it, particularly in technology, they may tell you what they want to see. That may have very little correspondence with what they'll use, and it may have very little correspondence with what will benefit them. And so I think we actually have to struggle in the sort of in our world in really trying to incorporate practices that get a little bit closer to what's being used in industry right now. Because what the approach in industry would say, let me create an early stage interface and then ask people to use it and iterate on that design until I'm optimizing for the outcome that I want. Do I want you to hit the little red button? Then I'm going to create 3 different versions of that and see which one makes you more likely to hit the red button. And then I'm going to iterate and create another 3 until we get to a point at which we're optimizing on the outcome that we're trying to achieve. And actually, that's the way that we design. We're doing much more of that these days. And that comes at the expense sometimes of doing the kind of deep qualitative inquiry, which I think really serves us very well in in-person interventions.
That's great. Kim has one more question. You want to go ahead?
Yeah. So at the very, very end of your talk, you said something kind of provocative, which you said we could ask you about. So I'm going to ask you, which is why you think digital interventions are the best, way to go with these populations. And I'd love to hear more of your thoughts, because I've kind of been thinking the same thing and thinking going more in that direction with some of my work. And I'd just love to hear your thoughts about that.
Yeah, so I'll just go on the hyperbole parade here. Okay, so we know that folks in these populations are more likely to own and use mobile devices, and not just use the mobile devices, but use the mobile devices in the ways that correspond with the ways that we develop interventions. That is, like, they're more likely to watch the videos and use apps and to use text messaging and use interactive voice response. All of these kinds of things. That's all true. It is true that they are less likely to have other, that is to say, like, we have moved into a mobile first world where most people are kind of developing for mobile before they go to web, which works great for medically vulnerable populations because their primary connection modality is actually through mobile devices. Facebook, Twitter, Clubhouse, used to be Pinterest, no longer true. LinkedIn at the very beginning are all disproportionately comprised of underrepresented minorities in their populations. Clubhouse, which is the latest hottest thing, disproportionately Black. Twitter, disproportionately Black. It's not just that these things are being used, they're being used at excessively high rates. And so when you think about the challenge that we have in the health systems here in North Carolina, which is that if I'm trying to figure out how to get you into the health system to take your A1C, do I send you mail? Right. Do I make a telephone call, particularly in this area, to a landline phone, like with such churn that we see there? People have to drive 20, 30 minutes to get here. It's not like they're passing by very often, so you're not going to hang a billboard. There's really only one way, right? Again, I'm a little bit hyperbolic here, but I think I used to say in the old days when I lived in Boston, if I could create a technology that would allow us to keep track of people when they change their telephone numbers. Like, folks I was working with in Boston change their phone numbers 3 times a year. If I could just figure out how to keep track of them when they change their phone numbers, I'd have something. Well, we can now do that with every social media platform there is. And the fact that they're using it makes it the better strategy.
Okay, well, we're a little past 1, unless someone has another burning question. We just want to say thank you for being here, and we could give them a round of applause.
I appreciate it. Thank you so much.